So hello, and welcome to the third of 8 installments of the ADIEM webinar series, How to Be a Successful EM Applicant. My name is Tiffany Mitchell. I'm an attending at the Mount Sinai Hospital in New York. We've got a large number of attendings and residents from across the country who are really excited to share their expertise with you about how to be successful in emergency medicine. So we're going to be going through a number of topics, but you can ask questions by typing them in the chat box, and we're going to address them as we go along. So without any further ado, I'm going to go ahead and hand things off to our first two speakers, Dr. Julie Jung and Kathleen Wittels.
Thanks so much, Tiffany. I'm Kathleen Wittels. I'm the Director of Student Programs at Brigham and Women's Hospital in Boston. I'm really excited to be with everybody tonight. The first section of this talk actually, takes you before you even get to your clerkship, right? So I think it's important to remember that the impression you're making begins before you even show up in the emergency department. So the most important things to sort of think about as you're getting ready to do a rotation is be prompt, be professional with any paperwork or training that's asked of you. If you receive a course syllabus or a manual, make sure you read it. You don't want to be the person who's asking all of the questions that were on page 1 of what was sent to you. Find out ahead of time what you should bring with you. So, should you have scrubs? Should you bring your own scrubs? Is the hospital going to provide scrubs? How about a white coat? Anything that would be helpful for you to have downloaded onto your phone. Is there a EMR app that you should have on your phone that'll help you be more efficient in the emergency department? Is there anything you need to bring beyond a stethoscope? And then finally, I would say that, if it's your home institution, you'll obviously know multiple people who have rotated before you. So take advantage of that. Ask them questions, find out, tips on how to be successful. If you're doing an away rotation, you could always ask the coordinator where you're going, if they could perhaps put you in contact with someone who's done the rotation before. So take advantage of that opportunity to just get some information before you get there. So biggest things you want to know for the first day you show up in the emergency department. Again, these are all things that should be addressed during your orientation, recognizing that when we're currently in the pandemic, your orientation might not look like it traditionally does. So what you want to make sure is after you've had whatever orientation you're going to have, you can answer these questions for yourself or you've asked about them. So you want to know where to go for your first shift, who's going to hear your patient presentations, what is your role in order entry and in documentation? In some institutions, students write notes and others they don't. If you do write orders, who is going to be co-signing them? And does that flag for them, or do you need to notify them as soon as you put in orders? Because we want to make sure we're not delaying patient care. Who supervises you when you're doing procedures? Critical care is always a really fascinating and wonderful part of emergency medicine, and so it's good to understand what your role is. You want to be able to learn as much as you can about critical care, although likely you won't be sort of leading these patients independently like you do other patients in the emergency department. So understand what the expectation is. If there's a critical care alert, where are you supposed to go? What are you supposed to do? And that sort of ties into the next point, which is the departmental layout. Know where generally things are, so that if you are supposed to be somewhere, you know how to get there. And finally, just understand who is assessing you on your shift and how that process works. The next thing I'm going to talk about is obviously specific to this year, and unfortunately we don't know for quite how long it's going to be relevant, which is just to understand that COVID changes the landscape of everything. It's upended medical care, it's upended medical education. And this is going to affect you in different ways depending on where you're rotating. So institutions vary in the restrictions that they place on students participating in the care of patients under investigation for COVID-19. Some institutions allow students to see patients with either confirmed or suspected COVID, others do not. And so you want to understand what is the expectation where you're rotating. If you're not able to see these patients in person, you still want to make sure that you're able to listen in on other people's presentations, and so you can still learn the content, understand the considerations. You can read about these patients so that you're not sort of eliminating a section of your medical education that you could have otherwise gotten. So whether you're seeing the patients are in person or not, there's still an opportunity to have exposure to this patient population. Understand that ED workflows and supervision structures may be different. And so you just want to be flexible in your thinking and in your behavior in the emergency department. Ask questions if things aren't clear to you, but just understand that departments are sort of working in different ways than they perhaps traditionally were. One consideration for our patients is that they may have limited access to outpatient care and follow-up, and sometimes that actually changes what we'll do for them in the emergency department. So it's just something to keep in mind. If you're perhaps going to delay a test to the outpatient setting, make sure you understand whether or not that patient is likely to be able to get that test. And if not, is it still a safe disposition, or do we need to consider doing things a little bit differently? PPE is obviously a critical thing for all of us right now to keep ourselves safe. One of the things you want to be sure of, whether it's your home institution or visiting, probably more it would come up if it was an away rotation, how is PPE handled? Is it going to be supplied to you? You know, make sure you're not expected to show up with your own N95s. I think that would be extremely rare. Most institutions, I think, would provide the PPE that they need you to have, but it's something that you want to just double check and make sure of before you show up for your rotation, particularly if you would have to travel. And then the last point I just want to make is about personal exposure risk. So I think that, you know, everyone has different circumstances, whether they are, you know, living with or around people who are perhaps at higher risk if they do get COVID-19. Perhaps some of us are at higher risk. And so I think you just have to do a little bit of a self-check of both your exposure concerns as well as, you know, making sure that you're confident that you are being put in a position to be successful while keeping yourself safe. I always tell my students, you know, everyone has a different threshold and comfort level. And so what you want to do is make sure people are generally very respectful of operating within your comfort level. So you just have to do a little bit of self-reflection to see how you are feeling about that. I'm going to turn this over now to Dr. Jung, who's going to take us through the rest of the preparation phase before you start your clerkship.
Hi guys, I'm Jules Jung. I'm an attending and longtime clerkship director at Johns Hopkins, and I'm also the president of CDEM this year. So I'm going to talk a little bit about getting yourself into the right mindset and sort of mentally preparing yourself to be a superstar on your rotation. Next slide, please. So there are a lot of common pitfalls that we see students fall into during their emergency medicine rotations. And some of them seem so obvious and you think this would never be me. But every single year, we have at least one student who is a fantastic residency candidate, who on paper looks like they'd be great in the program, but they have given attitude to a security guard or been rude to a secretary, and they're not considered for our program for those reasons. So you really want to be careful about being polite, professional, and deferential with everybody who you interact with. And you should understand that emergency medicine is a team. And the team isn't just the doctors and the nurses. The team is everybody in the emergency department. We all know each other. We all work together. And if you fall on the wrong side of any of those people, it could really harm your competitiveness for training at that program. I also really want to encourage you to commit to using patient-centered language and attitudes. In emergency medicine, we often see challenging patients, patients who frequently use the emergency department, patients who use the ED for non-medical reasons. And you can sometimes see inappropriate language and attitudes modeled about those patients, which is just an unfortunate reality of our specialty. But don't let that be you. Every patient deserves to be there. Every patient deserves our respect. Every patient deserves our compassion. And if you show that 100% of the time, you're going to earn the respect of the people you work with. I think that others are going to touch more on understanding your limits, so I'll be brief on that. the bottom line is that we will never, ever, ever think less of you for asking for help when you need it. If you're in a situation where a patient is unstable, where you don't know what to do, where you're trying to do an unfamiliar procedure, we're never going to think less of you for asking for help. But if you do something you don't know how to do and you harm somebody, we are definitely going to have a negative impression of your judgment. So please don't hesitate to know your limits and don't be afraid to ask for help when it's needed. Think about how you're going to show your interest, your enthusiasm. We like to see people in emergency medicine who are proactive, who are self-motivated. We don't want to have to tell you every little thing to do. So think about ways that you can do that. Go check on your patients on a regular schedule. See if they need anything. Check in with the team. Check in with the nurses. See who needs help with stuff. Try to always maintain a sense of what's going on around you so you can find ways to contribute. And lastly, prepare to take ownership of your patients. We don't want you to be following along with your patients like you might have been as a third-year core clerkship student. We really want to see you stepping up and being the doctor for the patients that you're taking care of. And that means staying on top of their results, staying on top of what's going on with them, having the best understanding of their history and their current condition of anybody on the team. Next slide. Another thing I want to do right up front is give you guys permission to be wrong. So let me say it for the record, nobody in emergency medicine expects you to have mastered the entire specialty before you come for your medical student rotation. If that were the case, you wouldn't need to do a residency. So that's not what we want. What we want to see is how well you can think and reason through clinical problems. If you come up with a wrong diagnosis, that's no big deal if you can show us a reasoning pathway that led you there. If you miss a diagnosis in your differential or you come up with something that I don't think is substantiated, that's not a problem. That's a teaching point. But if you're not able to generate a differential, if you're not able to synthesize clinical data and show me your clinical reasoning skills, then that's a problem. So don't be afraid of being wrong. Don't be afraid of hazarding your best guess as to what might be going on with the patient, and be open to feedback when we give it to you. When I say, hey, you know, it's not this, it's really that. Next time you see a similar patient, remember to look for that. Remember to look for that thing, because if you're not able to incorporate that feedback as you move through the rotation, that's going to be a source of concern. We really want to see that you're learning and growing as time goes on, not that you're perfect at the beginning. Next slide. Last thing I want to talk about is situational awareness. We have all had the medical student who comes up to us to tell us that our patient's creatinine is 1.7 right in the middle of a cardiac arrest. That is not a good time to talk about that particular issue. So have some self-knowledge of when people are open and available to talk to you and when people are less open and available to talk to you, and have a sense of how urgent what you have to say really is. I don't want to hear about a creatinine of 1.7 while I'm coding somebody, but I might want to hear about a potassium of 8.2, so I'm not coding two people at the same time. So when you really do have important information, don't be afraid to share it. However, just be mindful of what's going on around you and how much bandwidth the person you're talking to has to interact with you at that moment. We mentioned this before, but anticipate the needs of your team. Know kind of what things are going on, not just with your own patients, but with the patients on the rest of the team. Think about who might need help with a procedure, getting supplies set up, who's going to need records sent from another hospital, and you could help out with that process. So stay abreast on everybody, not just your own patients. And the more sort of knowledge you have about the overall clinical milieu, the more helpful you'll be and the more favorable of an impression you'll create. And then another piece of situational awareness is knowing when you should stick up for yourself and say, hey, I would really love to do this procedure if that would be okay, versus when it's maybe too emergent or too challenging of a situation for you to do that. And like I said before, know your limits. Please don't undertake doing anything that you shouldn't be doing just to show that you're strong, because we're not going to interpret it that way. We're going to interpret it negatively. So make sure that you know what's going on around you and that you use good judgment in communicating and participating in patient care. All right, I'm going to turn it over now to Dr. Mitchell and Dr. Laoteppitaks to talk about tools and resources for your shifts.
Okay, hey, Kat, can you go to the next slide? So these are a couple books that I think are really, really important to have on shift, in particular the Chief Complaint. And just as a forward, I don't get a single cent off the sales of any of these books, but I will say that the Chief Complaint is a really well organized book. It fits in your white coat pocket. Everything is organized by the Chief Complaint. So abdominal pain, chest pain, difficulty breathing, headache, and it literally lists, you know, the differential diagnoses, the labs you should be considering, and potential workup. So, you know, the thing about, as a medical student, we know that you don't know everything. We don't expect you to know everything. I do expect you to look it up. So you're going to get one patient, you know, every 1 to 2 hours. So you have the time. So after you see your patient, to go back and pull out your phone, pull out your textbook, and just look up the workup. So that's something that there's really no excuse for not having a good differential and, you know, potential treatment, potential plan, what you want to order, what labs you want to order. And, you know, so these are, and it's not, again, you have the time. On my rotation, after every single patient, I, you know, step aside, flip out the book, pull up to date, and just look up and think about what I wanted to do. And that's how you should approach every single patient that you see. IMRA Pressor-Dex and antibiotic guide, I use, you know, to this day. The Pressor-Dex is going to give you a list of all the really critical care medications like pressors and antihypertensives. The antibiotic guide is going to give you a basic guide on how to treat most common infections. So these are also really small books that are easy to throw into your white coat and definitely useful. Next slide. This is another book that's really great if you have any urgent care shifts or fast track shifts. It's going to cover all the basic minor scary emergencies, so minor fractures, hemorrhoids, foreign bodies, things like that. It's not small enough to keep in your white coat, but you can have it at home, and it's something you can use to look up before or after your shift. Again, it's super useful, and I really like it, and don't get a dime from the sales of it. Next slide.
All right, so I'm going to talk a little bit about some of the procedural resources that you can rely on when you're on your shifts. And first thing we want to talk about is the New England Journal of Medicine has some very well done procedure videos that talk about the indications, the contraindications, the equipment you'll need, pretty much everything that you would need to perform a procedure in the emergency department. Lots of different procedures such as thoracentesis, arthrocentesis, placing IVs, central lines, intubation, great stuff. The MRAP guys also have a very good series of videos on their YouTube page that has a number of procedures as well. A little bit shorter, more bite-sized, manageable chunks of procedural information than the New England Journal of Medicine videos. And then Scott Weingart's got his MCRIT YouTube page where he also has some really great videos that you can review for procedures that you might need to perform in the emergency department. Next slide, please. So as far as books are concerned, we mentioned a couple of these earlier. The EMRA Antibiotic Guide and I believe the EMRA Fundamentals Guide actually come to you for free, I think, if you're an EMRA member. So consider joining EMRA if you haven't already. The antibiotic guide is super useful. As Dr. Mitchell said, I use it on shifts pretty much every day. There's also an Android and iOS version that you can install on your phone. Emergency Medicine Secrets is also very helpful. Lots of folks really enjoy that book. One of the things I want to mention is both the Tintinelli Emergency Medicine and Rosen's Emergency Medicine are kind of the main two textbooks that people talk about in EM. I don't necessarily recommend purchasing them, as I think a lot of residency programs will give you a copy of one or both when you join up as an intern, and they can be expensive, so check your school's library first, but they're very helpful. I find that Tintinelli is not quite as in-depth as Rosen's is, and so if you really want to get into the nitty-gritty of something, I would recommend maybe taking a look at Rosen's first. 5-minute emergency medicine consults, also very helpful, very small kind of bite-sized things that you can look at quickly while you're on shift. And as far as websites, WikiM is a great wiki that's managed by emergency medicine residents and attendings. It's free, very up-to-date, lots of easy to reference material. Rebel EM is a great website that's got a lot of evidence-based emergency medicine. So if you want to kind of get into the nitty-gritty of some of these papers that are coming out that may or may not influence future practice, really great resource to look at. Life in the Fast Lane has excellent EKG resources and additional information about managing things in the emergency department, so take a look at that. And as far as podcast goes, both EM Basic and Core EM are really geared towards kind of core emergency medicine knowledge, things that you need to learn as an intern, things that will help you really do well on a shift. And MRAP and MCRIT are very popular as well, although they do kind of delve into things that are maybe a little bit more cutting edge, maybe not necessarily standard of care, but things that are interesting to listen to and to kind of broaden your horizons. So those are both really well received. MCRIT is free, I believe. MRAP you might get for free with an EMRA subscription, but they also offer, I think, student discounts on membership. Next slide. So next up is going to be Dr. Holden and Dr. Haber. We're going to talk about evaluating patients in the emergency department.
Great, thank you. My name is Dr. Lynne Holden. I'm a professor of emergency medicine at the Jacobi Montefiore program and also chair of the emergency medicine section of the National Medical Association.
Hi, and I'm Dr. Haber, and I'm faculty at University of Nevada, Las Vegas EM program.
Great, thank you. So you're here, you're about to go see your first patient. So what exactly do you do? We're going to talk a little bit about how you approach that patient. The first thing is you want to make sure that you're respectful of the patients. The patient, chances are, doesn't want to be there, but they're relying on you to help them out. So how do you recognize a patient who could be sick or who is not sick? First of all, you want to look at their vital signs. Vital signs are indeed vital. Not only do you want to look at them in a one-shot deal, you want to look at them over the course of time. So you want to trend the vital signs. That's very important. Also, you want to observe the patient. You want to make sure that their airway is patent, that they're breathing, that they're not exsanguinating in front of you, and also that they don't have a new disability. So vital signs and ABC are things that you should be able to spot right away. You want to look at the patient, and it's often said, look at the patient when the patient doesn't know you're looking at them, because you'll learn a lot. But you want to make sure you hone in on those practices of surroundings, as Dr. Jung mentioned, to be aware of your surroundings, and you always want to be aware of your patients. You want to make sure that as you talk to your patient, you get a history from the patient, that you're thinking about what could possibly be going on with this patient. There's a saying that says worst first. So you always want to think about what could be happening with the patient that could essentially kill them. And that should be at the top of your differential. And that should be what you're thinking about getting data about, whether it be blood tests, radiological test. You have to always be thinking about which tests you're going to get to find out what is going on with your patient. And then you want to make sure that you put it all together before you present your assessment and also your plan. What is it you're going to do to help find out what is going on with this patient? Realize that your assessment may change. Chances are that your assessment may not be that of your attending physician, but you want to make sure that's important information for all of us to know. So again, vital signs are vital. Make sure you check out your ABCs. You've learned your ABCs from the beginning. They're sticking with you. You want to look at your patient. You want to make sure you collect appropriate data at your disposal, and you want to make an assessment of your patient and also your plan, remembering worst first.
Thank you. So now we're going to talk about caring for the difficult patient or the challenging patient. So I want to talk first about that patient who you are caring for that you witness could be violent or combative, or also who's maybe making you feel uncomfortable. So one of the first rules to EM is that you have to protect yourself first. If you're going to be able to care for your patients, you first need to care for yourself and your team. So it's really important, especially as a student, that you know that the residents, the attendings, your nurses, they're all on your side. They all want you to succeed and they want you to be safe. So I always let my students know, please approach me and let me know if you ever feel uncomfortable or you ever feel unsafe. This is something I want to know about so I can make sure to take care of it. And so that comes into knowing when to ask for help. And this might be a theme that you hear tonight. That's a really important topic because the emergency department can be a really dangerous place for all of us. And it's vital that you understand when to escalate. So no one will ever judge you or fault you if you have a concern and you bring it to that higher level, to your resident, to your attending. And you could also know that your nurse and the rest of your team is on your side and they are also available to help you out when needed. I can't count even the amount of times my nursing staff has helped me out of a bad situation. And then I want to talk about the more challenging patient who's challenging because they're not maybe the patient that you studied in medical school, who gives you that clear history, who's easy to examine. And there's a lot of those you're going to see in the emergency department. First of all, we don't know our patients when we show up for our shift in the ER. We'll see everybody, we don't have a rapport, and we don't know what we're going to get when we come in for a shift. So it can be challenging to figure out what's going on with your patient, especially if they can't communicate for various reasons. Maybe they have a cognitive disability like dementia, or an exam is difficult for several reasons that maybe the patient can't follow commands, for example. So here's where I talk about advocating for your patients. One of our jobs as an ER physician is to do the best that we can to get as much of the history and exam as possible. So sometimes that means talking to a family member or making a phone call, looking through old records that we have through the EHR. For doing a proper exam, that might mean asking for help to rotate a patient or turn them over or derobe them, for example. So this is that concept of taking initiative, taking ownership, and here's where that comes in, especially for the more challenging patient. So thanks, Dr. Holden.
Okay, so the next slide, we want to help you delineate who's sick versus not sick. And this circles back again. You're going to hear a lot of repetition to what Dr. Jung was saying as far as being situationally aware, not aware only of your patients, but of the patients who are in the emergency department. Remember, it is a team effort, a team sport, emergency medicine. So we talked about vital signs. We talked about the trending of the vital signs and the fact that vital signs are indeed vital. So if you see that the vital signs are becoming unstable, you have to realize that this patient could very well be sick, and it may be subtly unstable. So for example, a younger patient who comes in with abdominal trauma may not show vital signs that are unstable until very late. But you have to notice even the slightest change in vital signs for the worse, and make sure that you bring that to the attention of your supervisor. A patient that's in distress, again, patients come in and they can really quickly become very ill. So you have to constantly observe your patients. And again, a lot of times you observe your patients when they don't know that you're looking at them, or your peers or your other team members may tell you something about the patient. So please listen and realize that everyone is there to take care of the patient. Again, make sure that you consider any emergency diagnoses for each patient. Worse first. You want to be able to sleep when you go home at night. So you want to know that you've done the best thing by the patient as far as trying to find out why they came into the emergency department. So just realize again that patients may come in and they may look well, but they may quickly become unstable, or they may become very ill. So it's important for you to continually observe them. And then when in doubt, again, we're going to say this, know your limits. You're attending residents, nurses, it's a team. We're all there to take care of the patients. So if you feel that your patient is not doing well, or if you feel that you're uncomfortable around the patient, please let someone else know. Many of us have been doing this for many years, and we still ask for help. As my husband would say, my favorite word is security. So you want to make sure to make sure you ask for help, and that actually makes you look, as Dr. Jung mentioned in her speech, makes you look very good, because we know that you are able to ask for help, that your pride doesn't get in the way, and that you are someone who is more desirable because you did ask for help.
So these are some of our concluding thoughts. Again, knowing when to ask for help. This is just so important because, like Dr. Holden says, this tells a lot about you, that you had good judgment to escalate and that you understand that we all work as a team here. We're all here to look out for each other, and you're never working alone. And then knowing your limits. Again, knowing when you need help and when you're out of your comfort zone. And this came up also earlier, this will be different for every person. So don't compare yourself to maybe another medical student working next to you. Be honest about where you are. Everyone has come in with some different experience. Some medical students have an EMT background. Some have maybe done more EM rotations. And as faculty, we know this about our students and we expect this. So it's more important that we see your growth and that we see that you're someone who's teachable. In fact, we actually love teaching. That's why we're faculty. So if you give us an opportunity to teach, we couldn't be happier. And the concluding remark is that EM is a team sport. I think that really needs to be reiterated because that's really why all of us chose to go into EM. We love caring for our patients as a team, and that's really what gives us the most satisfaction when we have success as a group, and this is truly a team celebration. And when there's a mistake, we own it as a team as well. So recognize that your team is not only your residents, your attendings, but it's also the staff you work with, your nurses, your respiratory therapists, your EKG techs. There's so much you can learn from them. So introduce yourself to your whole team, let them know that you're here to learn, you're also here to help them. And also on your team are your other medical students that you're rotating with. So get to know them too and look out for each other. I think as a faculty member, I know we're always looking at how that student interacted with the other students, because that's a good gauge for us on how that student will act with their other residents when they're a resident. So with that, we'll end our part of the talk, and I wish you all good luck and can't wait to meet you when you're a resident. And we'll pass it on to Dr. Montano and Dr. Ward-Gaines.
Thank you very much. My name is Manuel Montano, and I'm the Clerkship and Medical Student Director at Denver Health.
And I'm Jackie Ward-Gaines. I'm the Director of Diversity, Equity, and Inclusion for the Denver Health Residency, and this year also Education Chair for ADIEM.
So the oral presentation, it's a fundamental component of what we do. And I think it's really important before we dive into the mechanics to talk a little bit about what the goals are. So first and foremost, what's the goal of this? It's a conversation to translate the complex process and take care of patients. The fundamental goal of this all, to get out, like it's been mentioned before, get our ego aside, is to take care of patients. So first and foremost, that's why we have this conversation. But then there's also a couple of important goals for you as students. One of them is to get credit for that hard work and the thinking that you've been doing. And the last is, mechanically, what's the goal of this presentation is to be concise, organized, and focused. We want to deliver this in 3 minutes.
One other important goal is to remember that you are a learner. And as some of the colleagues mentioned earlier, you wouldn't need a residency or if you came in knowing everything. So it's okay for your differential not to be correct, but this is a time for you to actually learn. Woolpall in his tool, the SNAPS tool back in 2003, talked about using a SNAPS presentation. And the two things I want to highlight here is the P for probe. So as you're doing your differential, you want to get a chance to probe your preceptor, ask questions. Like I said, we're at a teaching facility. That's what we want to get a chance to do. And then I want to highlight the S, which is select. And so you want to take something about the case that you're working on that you don't know and use that for some self-directed study. We want to see that you're able to direct your own learning. This will be a competency later and you will need this the rest of your entire career. And so remember the presentation, not just to show that what you know and how good you are, but also remember that you're a learner. And so you should get some value out of the presentation.
Excellent. And then, well, we talked a little bit about the mechanics, about what some of the goals are. These are some of the things that are perceived during your presentation that carry a lot of weight and they should be aware of. So in the oral presentation, you're not just talking about your patients, you're presenting your ability to perform a history and exam. Not everybody's going to be able to do a direct observed exam for you. So the way you translate this is what you're demonstrating in your oral presentation. You're also demonstrating your understanding of the pathophysiology and your ability to appreciate prioritized concern. What that means is, do you or do you not recognize sick versus not sick? That's something that we can translate in that oral presentation. And you're also translating your thoughtfulness, your organization, and that anticipation for the next step, which is what's going to take you from it's really going to increase it to the next level.
So finally, opening one-liner, that chief complaint. You really got to be able to get that chief complaint. You're guiding us through a narrative, and that narrative is an upside down triangle. You're going to start off with that chief complaint, that one-liner, and we want you to be able to hone it all the way down so that you take us there to what your differential diagnosis is.
So how does that one-liner get set up? Well, this is where you set the stage for your listener. There's a difference between a 56-year-old gentleman with superficial rib pain and laying out the information that your listener needs to start working on the case with you. So a robust one-liner, a 56-year-old gentleman, hypertension, hyperlipidemia, CAD with 3 prior MIs, presents with chest pain for 3 days. That sets the stage and is a really robust one-liner.
Now, once we have that, remember the whole goal is to be concise, organized, focused. Leave out all the prose. So although you asked an open-ended question, patients rarely will give you a history in such a form to be able to present that. So you have to weave through all the clinical narrative and be able to give us those important information, including the positives and negatives, so that I can think with you. Again, you're leading me there. So not just showing and telling, but being able to lead me there. Being able to take all of the mnemonics, such as using old carts or PQRST, and be able to put that in a nice, succinct fashion.
Perfect. So we're going down our triangle or our thought process that started broad, and we're thinking with you. The next step is the exam. It's been said before, we'll say it again, vitals are vital. And the best way to translate this is to interpret the relevant. You can read off to me the heart rate and the blood pressure and the respiratory rate, but maybe it's more powerful to say that there's a low normal blood pressure, and then unexpectedly, there is also relative bradycardia. Interpret that for me. In the exam, instead of giving us the entire exam piece by piece, which we expected that you did, give me the pertinent exam pieces. If someone comes in with chest pain, give me a full pulmonary exam, a cardiac exam, abdominal exam, possibly even a neurological exam. Same thing, you're helping guide us in your thought process so we can think with you.
So finally, you're summarizing, you're putting it all together. And again, in a quick, succinct fashion, and I should already be there with you because you've been guiding me through this narrative. And as you can see an example here, very succinct and to the point.
Getting back to the differential. So it's been said before, worst first. A mentor told me when I was a medical student, the rest of the hospital plays to win, but as an emergency doctor, you play not to lose. So we always think worst first. And a really interesting model that sort of tries to encapsulate that is the SPIT model, with that worst first being S, serious, worst first every time. P is for then after you give me the worst first, the worst 8 conditions that could explain the chest pain. Now you can tell me what's more probable based on the patient's presentation and exam. And then after that, I and T are for interesting and treatable. What else can we identify today and make a difference in?
Now we're talking about that robust plan. The plan, again, has 3 prongs, so diagnostic, therapeutic, and disposition. Sometimes I find that you hone in on diagnostic but forget therapeutic. It's a patient with chest pain, and you've thought about the x-ray, the EKG you want to do, but not even a simple pain medication for that patient. So remember therapeutics in putting together that robust plan. Also, what's very important about the plan is disposition. And I want you to think through it, not just knowing the patient is being admitted, are they being observed, are they being discharged, but start to ponder if they're being admitted, is this on a floor? Is it a step down in ICU? Do they need a telemonitor? Do the patient need a sitter? Get familiar with wherever you're rotating and what resources are available, especially for those patients that are discharged, so that they have appropriate discharges. Asking your resident and attendings for help on creating that discharge at a level that's good for that patient. Do we need translation? Does that patient need help even just getting home? Transportation, bus tickets. Start thinking about all the resources for our marginalized patients that the place that you're rotating at has available to you. You want to make sure that you don't miss one of the prongs in creating a complete plan.
Great. So to bring this all home, yes, you can do this in 3 minutes. I know this is daunting, but that's part of why this is an art and a skill. Earlier on, preparation is key. This has been mentioned before. Sure, notes can definitely help, and use them until you can ditch them. That's something that your supervisors are going to look at too, but if it helps with organization up front, maybe that's a way to start. And just a take home, practice doesn't make perfect, practice makes permanent. Keep on practicing this, and this will be a routine part of the way you present.
And you can scan the code here, and you will be able to get to the IMRA oral presentation, which some good and bad presentations, and get a good example of those, along with pulling up the article on the 3-minute EM presentation that was actually done by one of our faculty here, was on part of that team, Dr. Guth, and excellent resources. So next, we'll turn it over to Dr. Ali and Dr. Nazario to do feedback. Nazario.
Great. I really appreciate it, y'all. So this is a great segue into really kind of the next part. So you've gone and presented your patient, and now you want to know kind of what went well and what didn't. So feedback is super important to you during your clerkship because this is what tells you. Next slide, please. This is what tells you what went well about whatever it is that you did, whatever skill you demonstrated. But it also tells you what needs to be improved. So you can't get to, or you might get to clinical competence based off of just trial and error, but probably not. With feedback, we guide you to get to that level of clinical competence that you want. So how are you going to do this? So the first thing, and Dr. Wittels at the beginning stressed this, and I will stress it again, you have to know the expectations. You need to read the syllabus. You need to know the orientation information because you need to know your role. If you go onto the basketball court with a football, well, you're already behind. And the only feedback that you can possibly get is that you don't know what your job is. So know your expectations up front. Do you need to take sign out from somebody, or are you supposed to just pick up new patients and then present them to the attending? Know those things so that you can do your job well and do it as expected. The next thing I tell all of my medical students at the beginning of the shift is you have to have a goal. You can desire to be the best medical student, the best physician that is possible, and that be your goal. But you need a specific goal for a short time period, for a shift. Be it you want your presentations to be concise and organized, and you want to get feedback on that. Or maybe you're working on broadening your differentials. But announce that early so that the people that you are working with, the educators that are evaluating you and giving you feedback, have something to focus on, and so that they can help you get better in those desired areas.
Thanks, Will. I think that in addition, I think that it's also be specific about what it is that went right. Like you said, if you get positive feedback, what was positive about it? I chafe when I see other attendings say good job, but there's what was good about it, because it's the learner may be confused, sort of like feeling I didn't really get anything out of that. It's better to sort of ask for specific feedback. If somebody gives you good job, well done, what was so good about that? And I think that getting specific examples is helpful. And also sort of remember that the narrative is an important, but it's perception. If you're thinking this is a personal critique, it's not a personal critique. As many of the other presenters have talked about, we went into academics, we love to teach, we want to have that learner grow and prosper within that environment. So hopefully the beginning of your rotation, you're different during by the middle section of it, and then you're a totally different individual by the end That's a successful candidate for me, and one that I love to work with. Another point I would say would be, don't negate the feedback that you get from your residents, because sometimes a senior resident will give the same feedback that I'll give, but they'll get blown off, and I don't know, for whatever reason I get credit for it, but I sort of take that as a measure of, can this individual work with my residents? Because that's one example. When is the best time? As you see in this slide, it's sometimes in ED there's never a good time, but natural end is right after your shift. If you and your attending are ending your shift together, maybe that's a time to say, hey, can I get a cup of coffee with you, or walk you to your car, to your office, or something like that. That's a nice way to sort of segue into getting some one-on-one time. Or perhaps if you're feeling like, hey, the census is starting to pick up, the waiting room's starting to get loaded up, then maybe right in the middle of the shift is the best time to grab the evaluator's attention, or immediately right after a presentation, right when it's hot, because I sort of can pick 3 things and I can just talk to you about it. And I think that that's a good way of doing it. Will?
That's great, Stephen. So of course, actually, let's go back one. There are bad times to ask for feedback. So Dr. Jung mentioned that probably asking questions in the middle of a resuscitation, so a trauma or CPR comes in. That is a terrible time to ask me for feedback on whatever it is you just did, or to tell me follow-up information on your patient. So be aware of the situation. Also, when it is really busy, and I understand that when you walk into the emergency department on your first few shifts, it is going to always seem chaotic and busy, because in general it is. We don't have sit down time while we wait for the pager to go off. We're constantly moving and doing things, but sometimes what we're doing is grabbing a snack, or building the team as we talk about other things with our colleagues. Those are great times to ask for feedback, but not when we're getting crushed and I have to go see 5 new patients all at once. Hold it until a little bit later.
I think here, listening for feedback, being an active listener is quite an important skill. I had to learn it along the way. I think that it's often you hear 1 or 2 negative comments, and again, if you're getting asked a lot of questions, sometimes it's a matter of that person's style. I have a different, more Socratic method of sort of trying to figure out what you're doing. There's the feedback sandwich, which was a nice comment. The meat of the subject is going to be sort of a harsher critique or something slightly negative, and then you're supposed to bolster it with another positive comment on that side. That was in vogue maybe 25 years ago. We had another one where you feel like you're getting asked tons of questions and you're being pimped and you feel like you're on the ropes, and this attending won't let go of you. Realize that we're probing, and that's a real question, because I'm trying to sort of figure you out and trying to see how you're thinking and why your thinking is the way it is, and can I work with this? Is that somebody who's going to be creative? Somebody who's going to be able to navigate the waters that are going to be ahead of us as an EM doctor, because we know what it takes to get there, and that's receiving that feedback and implementing it. So I don't expect you to get it right the first time, but sort of come back to me with the answer the second time, or at least let me know that you've incorporated what I've spoken about it next time we meet. And it's okay to make mistakes. You've heard this a couple of times today. We expect you to make mistakes. It's not a end all be all. It gives me an idea into your thought processes, and that's fine. That's why you're going to be here.
Yeah, so the last little bit of this topic, I want to go through some feedback that I frequently give to medical students, and how you go ahead and start working on making that better. So a little pre-feedback even. So the biggest thing that I give feedback on is presentations. So the organization of the presentation, or the succinctness, the conciseness of that presentation, and give me just the information that I want to know. But what you have to understand is that while giving those presentations that is a clinical skill, it is also a public speaking skill. And the only way to get better at any skill is to practice. And what I would encourage you to do, either before your clerkship or during your clerkship, especially after you've gotten some feedback on your presentations, is go and look up some clinical scenarios, read some HMPs, and then go to the mirror, look at yourself, and present to yourself. And you should even record that, and so that you can see what's happening. You may perceive that maybe it was going great, but then you're going to listen to it, and maybe you're going to find out that it wasn't quite as smooth and concise as you thought it was. I would encourage you to time it. Dr. Montano mentioned that 3 minutes, that's how long you got. So time yourself so that you can work on getting those presentations into a reasonable amount of time. The next thing, the next most common thing that my faculty give feedback to medical students on is their differentials. And frequently it's, you need to have a broader differential, or make sure you're thinking about the emergencies. What I would encourage you to do is realize that we see a lot of the same stuff. Emergency medicine is, I think, the broadest field out there. I think nobody would argue, but with that, we see a lot of similar complaints, a lot of chest pain, a lot of dyspnea. If you were to think about probably the top 5 or 6 complaints that come into the emergency department, you would probably, that would probably take up 70–80% of the patients that we see. And so if you take those complaints and you utilize the common differentials for those things, the life-threatening things, then you're not going to have to use your brain power to come up with that de novo every time. And you're going to walk out of that room already thinking about those things. And then the brain work is in rank ordering those in the worst first situation, and then on down. So please memorize the common differentials. It will save you.
Yeah, thanks, Will. And I think the other part is just patient follow-up and coming with the flow and making sure to recess the patients. I'd like to introduce, I guess, the next two, which is Dr. Camejo and Dr. Kuzel.
Hi, everybody. I'm Melanie Camejo. I am the Assistant Program Director at the University of Missouri, Kansas City, and I'm also the Clerkship Director.
And good evening, everybody. My name is Dr. Aaron Kuzel. I'm a PGY2 resident at the University of Louisville, but I also am a member at large for the SAM RAMS board.
So this is the last section of this topic, and everyone's already kind of talked about teamwork. So as the common saying goes, teamwork makes the dream work. So one of the things that draws a lot of us to EM is the teamwork aspect of our field. We are never alone. We rely on one another to help provide the best patient care that we can. So when you're on the clerkship or visiting a different institution, you are now part of the team. So we are looking for students who can be part of the team when looking for potential residents. And I can't tell you how happy it makes me feel when I have nurses come to me giving medical students compliments because of how well they did being a part of the team. So becoming one with the team. First and foremost, make sure that you know that you are part of the team. I feel like a lot of medical students will just say, oh, I'm a medical student, my role doesn't matter. Your role does matter. You are the newest person in this care team, and you are in charge of your patients today. Your role is important, and you need to know it, and you need to believe it. I can easily tell the difference between a medical student who believes this versus one that doesn't. So before you walk into your shift, know that you're part of the team. I also can't stress it enough how important it is to introduce yourself. There's tons of learners in the emergency department, so make sure that you identify the residents and the attendings that you are working with and introduce yourself. Also introduce yourself to nurses, case managers, social workers, anyone new that you're meeting. It doesn't hurt to say, hi, I'm a medical student and I'll be working in the ER today. Because communication is key when you're working in the ER, especially with nurses. So you are part of the patient care team. You will be putting in a lot of orders. There will be a lot of changes made, to your patient, but keeping them updated is key. So find the nurse that you're working with, say hello, let them know what orders you put in or kind of what the care plan is, and always remember to say please and thank you.
please and thank you will go a long way when you're talking to nurses, case management, social workers. Everyone's stressed out, but when you hear that simple thank you or yes, please, it can turn someone's day around. So on the next slide, we'll kind of talk about how to be humble and hungry.
So if you haven't noticed by now, based on what Dr. Camejo, Dr. Jung, and Dr. Holden, the rest of my colleagues have mentioned, that the overwhelming majority of your performance is going to be based on how you function as a member of the team. And so I want to give some advice that one of my old Appalachian physician mentors gave me. And he always told me in medical school as well as life, you should come humble and you should come hungry. And what he meant by that was be confident in your abilities and what you've trained for thus far, but know your limitations, as my colleagues have mentioned. Be appreciative of the opportunity that you have to be in the department and to be able to work as an emergency medical resident or medical student, but even more so, the privilege that you have been given to take care of patients and that responsibility. As for knowing your limitations, obviously make sure you are vocal if you have concerns regarding what you don't know. Not just being uncomfortable with a line or intubation or some other procedure you've never done before, but a laceration that you may not be comfortable with. Maybe there's some muscle belly that you haven't seen before, or it's larger than what you're used to and you don't think you can handle it with simple interrupted sutures. These are times, even with a laceration, you may feel kind of not confident in yourself, and that's okay to ask, even if you think, oh, they expect me to know lacerations. No, we expect you to know your limitations and to ask for help. It is always better to be a willing participant and assistant than to cause harm to a patient because you are not open enough with your team. In my experience, I have never lost points on an evaluation because I verbalized my discomfort with a procedure, but I was always willing to assist or to help in any way that I could. And as one of my colleagues had mentioned, one of the best compliments you can have as an applicant on your evaluation is to be teachable and to be mentioned that he or she is very teachable. We all know, everyone here knows that as a fourth year medical student, you're not going to be at the level of a third or fourth year resident, but demonstrating that you can accept feedback and turn that feedback into actionable results, it will show that you can learn from your mistakes, you can make yourself better, and you can be coached. So on the next slide, I'm going to talk about a little bit more about how to be an effective team member. And so as most of my attending colleagues can probably not say but I can say as a resident is go ahead and embrace the SCUT. And so what does embracing the SCUT mean? Much of your performance as a medical student is determined by your ability to work as the team, as mentioned before, but most program directors and residents will rank you based on if they could work with you and if they think you would be someone they could depend upon in the trenches. Nobody wants to be with the arrogant person that thinks they're all the hot stuff in the trenches. When the going gets tough, you want somebody that you can depend upon. And so this can be separated in your role in moving the department's flow and in patient experience and satisfaction. What I mean by moving the department is by taking on the responsibility of being eager to tackle laceration repairs that are easy because that helps moving the patient to disposition. Being willing to learn how to splint. If there's no ortho tech that's there, be willing to splint and help splint, or even when that becomes complicated, just being a great assistant. And I know this is crazy, but going back to your patients and reassessing your patients, keeping a monitor, checking on the vitals, see how they're doing. And that kind of goes along with taking care of your patient's satisfaction and their experience as well as their well-being. Providing blankets and knowing where those are, where those blankets are, shows you are taking concern for your patient as well as their well-being. One last thing would be giving updates on your patients. When their labs are done, let the residents know what you found. It demonstrates that you're looking for flagged labs or labs that are abnormal, but also helps tell the resident that this patient's ready to be dispositioned, whether that's discharged or admitted to a service. One of the biggest compliments you get, as Dr. Camejo had mentioned, is assisting the nurses. If the nurses come up to the attending and say, well, we really like this medical student because he or she really gets involved, that is one of the biggest compliments you can get. And you can do this by assisting them with having the patient PO challenge when they're not MPO and they're probably going to discharge, or ambulating the patient yourself. It shows that you're understanding the next steps in the department flow and you're assisting with that disposition and discharge. or even helping with the nurse get the blankets, as I have mentioned before. So in the next slide, we're going to talk about a little bit about taking care of yourself. You know, we talk about the teamwork, but if you can't take care of yourself, you're not going to be an effective team member. So adjusting to all the different shifts and the night and day differentials in emergency medicine are difficult. So I'm going to have Dr. Camejo on the next slide discuss a little bit of how to take care of yourself. We'll have the next slide, please.
Thank you. So basically what we do is not normal, right? In medical school, you have rotations, you work normal hours, you might have a night shift here or there, but in the emergency department, we do shift work. You know, we're working those 8, 10, 12 hours. Sometimes we work 3 to 11 and then 7 to 3 the next day. We have to flip our schedules after, you know, working a string of night shifts. And this is stuff that, you know, we did not learn in medical school. So how do we learn how to take care of ourselves and be successful on a clerkship rotation? So you have to try to have the same intensity every shift. So I always tell students, I want you to eat something, I want you to drink something, and I want you to go to the bathroom while you're on shift. There's no reason for you not to be able to eat and drink unless everything is just hitting the fan. But you should be able to take care of yourself while on shift. So bring that snack, bring that meal if it's during a mealtime hour for you, but come prepared. Have a big old water bottle and make sure that you drink your water while on shift. And so while you're working these, you know, different shifts, wellness is important. If you love something, make time to incorporate it. Going to the gym, riding your Peloton, reading a book. So whatever you like, try to fit that into your schedule. I often hear a lot of excuses that are just like, well, I don't have time to do that. No, if it's important to you, you will make time to do that. And I promise you, if you do it, you're going to have a better time on any rotation that you're doing. So adequate sleep is very important, and I'll go into that here in a couple of minutes. But like we all know, you got to take care of yourself before taking care of others. And something else is you got to have someone to support you. You got to have a person per se. You know, a lot of us do have friends in the medical field, and when we hang out, we're talking about cases or we're talking about stuff that, you know, we've seen. And that just might be a way that, you know, we decompress and deal with things. So make sure you have that person and make sure you have a safe space to talk about all of the cases that you may have seen. So on the next slide is flipping between days and nights. So I am a nocturnist, so I only work nights. And I've been doing this for about 3 years now. And it took me about a year to kind of figure out what worked for me. So flipping your schedule, not everyone's the same, everyone's different. But what I can tell you is that consistency is key. So if there's a certain workout that you like doing, make sure that you do it. When I'm trying to go to sleep, I have to go to sleep by 9 a.m. If not, it's not going to be a good rest and I'm going to wake up grumpy. When I'm flipping my schedule, I make sure to sleep between, you know, the same hours, but only maybe 2 or 3 hours in that same time period. So I can't stress how important consistency is. And finding your routine. So if you're having to sleep at odd hours of the day, silence those, you know, Ring doorbells, get blackout curtains. I would just get blackout curtains for the rest of your life if you can. Sleeping in the dark is super important. Earplugs work a lot, especially during the daytime when you're trying to sleep. Melatonin, fans. Everyone has their own different concoction, but definitely you'll find out what works for you. And then caffeine. So a lot of us in, you know, med school depend on caffeine to survive. Well, residency is a little harder. So I would definitely work on your caffeine intake before starting residency. I had to stop everything cold turkey, and then I started incorporating it little by little, but I never wanted to have to depend on caffeine. Everyone's different, so people make it work. But that's just something to think about, especially if you're always flipping your schedule. Are you going to wake up with a headache? So it's kind of finding out what works for your body. And I feel like since this isn't normal, you got to embrace it. So, you know, you're going to go into your EM clerkship and you just need to know that you're going to be working very odd hours. And so it's not going to be the same as everyone else. So it's kind of a mind game for me. So in my head, I tell myself, okay, I'm going to work, you know, the opposite of everybody else, but it's okay. I'm going to get through it. So when you're on your rotation, just know that your hours are going to be different, but it's okay because you're all going to get through it.
So lastly, the emergency department is filled with ups and downs. And often as a medical student, you will come across some difficult conversations, whether that's with patients or that is getting difficult feedback or difficult interactions with residents. So I kind of want to talk a little bit about navigating some of these difficult conversations. Now, this will be brief. It won't be a comprehensive talk about difficult conversations, but just talking a little bit through some of the things you may encounter. As we alluded to earlier, it's always difficult to be honest when you're trying to impress, but let me full-heartedly advise you not to fake it until you make it. I know a lot of us throw that phrase around pretty willy-nilly, but knowing your limitations and being honest with your team shows your strengths and weaknesses, but also allows you to demonstrate your ability to grow and learn. Never feel pressure to give false information, and never, ever lie. It is completely appropriate to say, again, I'm sorry I didn't ask, but I will next time. Remember, the first priority is always patient care and always taking care of the patient. And, you know, if you're not giving the correct information saying that you asked that, that may be a detail miss that could have a harmful effect on the patient or affect the patient negatively. As for empathy, there will be rough days on your rotation. There will be stressed out residents and sometimes attendings who may not be the nicest or the most welcoming on those days. And you're going to be that stressed out resident one day. So the best way to be part of the team is to always come in with a positive attitude. And when things get rough, try to be above that and try to keep having that smile on your face and approach every conversation with empathy and understanding. Obviously, if there's any abuse or the conversation makes you uncomfortable, that's not appropriate, and you should escalate that through the appropriate channels. But on the hard days and everyone's rough and the department slammed, just try to be empathy and always try to have a smile on your face and try to be a positive attitude and a positive change in the department. And finally, as we talked about with feedback, make sure it's always the appropriate times to ask for feedback, such as when the department's not busy or your resident attending is not overwhelmed. And use that feedback, even if it's bad, to make yourself a better physician so that the next shift, you take that, what you learn, and you shine through it and you get the match that you want and be part of that department. And so for the last slide, I want to thank you all for coming and for pursuing this difficult and rewarding career as an emergency physician. At this time, we'll open it up for questions. If you have some, feel free to put them in the chat and we'll be happy to answer it. I'm going to look here to see if there's any question. I think there was one really good question at the top. The question was, do most institutions have a designated day for incoming students to orient themselves to the hospital layout? If someone would like to take that opportunity to answer.
Happy to
I have
chime
actually
in.
answered that one in the chat as well. And the answer was yes before COVID, but now many orientations have gone virtual. So, you know, you might get all the rotation logistics on a Zoom call or something like that, but have less of an opportunity to really walk through the emergency department and familiarize yourself. So probably a good idea to take a little bit of time before your first shift and make sure you don't get lost.
Any other questions?
And I've put my email address in the chat in case you think of some questions afterwards.
There's another good question in the chat. What are some common mistakes by medical students that you all have seen? I see a lot of smiles and eyes moving.
I think that Erin touched on something that's really important. I'd rather hear I don't know than for you to make something up. If you didn't ask, if I say, you know, did you ask the patient if they have leg swelling and you say no, I'm assuming they didn't have leg swelling, so that changes my differential and that patient might not get the test that they need and we could miss something. So if you didn't ask, you didn't ask. Just say you didn't ask, and then next time, make sure to ask. So I think that's a big thing because I know you don't want to, you know, you don't want to ever admit that you didn't do something you were supposed to do, but I'd much, much, much rather hear, oh, I don't know, or I forgot to ask that, than for you to make something up.
I'd like to add that one of the things that I see often is that I go to assess the patient and the patient's fully dressed. If they're there for something on their toe, fine, they don't have to get undressed. But if they're for abdominal pain or chest pain, they should not be in pants and a shirt and they should be in a gown.
one other thing that I notice from time to time, and you have to realize as students that the schedule for emergency medicine is different than pretty much every other clerkship you have, every other specialty out there. So it can get a little bit confusing. So take a little bit of extra time to make sure you know where you're supposed to be and when you're supposed to be there, so that you don't end up missing a shift, because those times are precious. That's your time to learn and shine.
I just want to add that it's a privilege to take care of patients, so please remember to always respect the patient and give them their just time of your attention, and make sure that you call them Mr. and Mrs. Please do not call them by their first name. That is very insulting.
So someone else asked if we have any advice for students that are in the process of ranking residencies, and what things did we look for? I think that's going to be different for every single person. For me, for most people, I think location is big. So thinking about what city you want to live, because a lot of folks where they train is where they end up working. So that's always an important consideration. Size, there's a number of factors. It really is based on what's most important to you. 3-year versus 4-year. I think any of us can comment on that, but it's really, you have to think about what you value and what's important to you, because this is where you're going to be kind of building your career and your connections.
Dr. Mitchell, thank you. Yes, I would agree with that entirely. What I ask our students to do is be honest about what your priorities are. Once you know what your priorities are, you can build your list around that. Is your priority to work in an urban center? Is your priority to work in an academic center with a lot of research? Is your priority to match with a spouse or significant other? So as long as you have your list of priorities prepared, you should proceed from there. Definitely, like was said before, everyone's list is going to be different.
I'd like to add on that sometimes you'll see these lists of like, what's the best program or what are the top EM programs, and that's just crap. I mean, the best program is not necessarily the best place for you. If some best program is in the city and you don't like living in a city, you don't want to be in an urban environment, you're going to be miserable. And if you're a miserable resident, you're going to not do well in residency and you're just not going to learn. So the most important thing is to, as everyone else has stressed, is to really think about what's important to you, and is the program going to be kind of meeting those important factors. Oh yeah, good. Upcoming session, October 13th.
Dr. Ward-Gaines put up a really great comment in the chat, what feels right. A mentor told me when I was looking at places, if you can plot it on a spreadsheet, at the end of the day, it probably doesn't matter. And the gut and how you feel about a place, how you connect. I recognize it's a little bit harder this year with Zoom, but that connection and what feels right really ought to drive a lot of the thought process.
So there's another question in the chat. How much initiative can we take with doing things before presenting? For example, a patient we think will need an IV. Can we ask the nurse if we can help place it, or should we wait until after we present? That's an excellent question. So, I think I will never fault a student for getting things ready. If the patient has a lac, get everything set up. Find the suture kit, find the betadine. If you know this patient who's got a long cardiac history, who's coming in with chest pain, they're going to need an IV. Absolutely go to the nurse and say, hey, you're going to need an IV. Every institution is a little bit different in terms of whether you can actually place orders. You're probably not going to be allowed to place orders yourself. So always, run it by either your chief resident or the attending. But I'll never fault a student for anticipating what the patient's going to need. I think that's signs of a very strong student. Okay. So I think so we're a little bit over time. I want to be respectful of everyone's time, but I want to thank everyone for being here. Thank all the students who were able to join in. Thank you to all of our panelists. And again, feel free to email me if you have any questions you didn't think of. And thanks for being here. I hope you guys have a great night.